Thanks, Ash. Thanks to everyone at OrthoHub for the invitation. It's nice to be with my colleagues, and I'm really grateful to Gareth. He's already given a good little introduction to some of the things that I'm going to talk about today. So thanks for the opportunity to talk about a subject that is very close to my heart. I'm going to talk a bit about code red trauma, and similar to Gareth, I'm just going to go back over a little bit of the history so that people can see perhaps some of the mistakes we made in the past, how we've learned from them, and hopefully how we're moving forward. So I don't know if he's on the call, but I know Pete Bates is part of the group that helped set up OrthoHub. This is actually a photograph from the Evening Standard of a lady that Pete was involved looking after her care. Gareth's already showed you some videos of patients who absolutely meet the code red criteria. But this was a lady called Carla. She was a 32-year-old living in London, and she was injured very close to the Royal London Hospital a few years ago. She was a pedal cyclist just passing by Aldgate East Station, and she was knocked down, or the back wheels of a coach went over her. She was assisted by bystanders. The London Ambulance Service attended. She was trapped under the coach and in cardiac arrest very quickly after the time of impact. And then London HEMS, or London's Air Ambulance, attended to her. And she had what can only really be described as gold standard care from the team involved. The physician response unit, our medical team, also happened to be nearby and assisted. And the interventions the team delivered for her, knowing that she had a pelvic injury, suspected intra-abdominal and chest injuries, were they managed to extricate her from under the coach. They simultaneously performed a subclavian central line and blood transfusion, whilst another doctor performed a thoracotomy to provide aortic control, to allow volume loading and internal cardiac massage. They applied a pelvic splint and did basic hemorrhage control well. And fairly miraculously, they actually got ROSC on this young lady and were able to move her very rapidly up, literally about 600 metres up the road in an ambulance, to the Royal London Hospital. She had a code red declared. I'll talk a bit more about that later. But the response at the hospital was that she had consultant-led trauma team. She spent a short time in the resuscitation room, receiving blood products, and very quickly a decision was made that she had to go to the operating theatre for damage control surgery. And that surgery was performed by two consultant trauma surgeons, a pelvic orthopaedic surgeon who happened to be Pete Bates, two trauma consultant anaesthetists, and a wealth of theatre staff. And unfortunately, this lady died. She died about 5 hours after she made it to theatre. She intermittently lost her cardiac output, and ultimately her heart just gave out and could not be restarted permanently. And this case left everybody feeling pretty hollow. We had absolutely, LAS, HEMS and the hospital had given the best possible current standard resuscitation that was available at the time, and still she died. So I think the context of my talk is really about how we've evolved, what we can do better, and how as a group of specialists we can endeavour to save more of these patients' lives, as exsanguination or bleeding to death is still the major cause of loss of life in trauma patients internationally. I just want to take you back to 2003. This was the first paper that actually described acute traumatic coagulopathy, published by Karen Broey and Tim Coates. And it was based on London HEMS patients. They took 1,800 consecutive HEMS patients, not just code red patients, and they had their clotting measured. The blood sample was taken at the scene of the incident, so sometimes as quickly as 15 minutes after the time of injury. The blood samples were then run on something called a sonoclot machine at the Royal London, and their clotting was measured. And that was quite sophisticated technology at the time. What they showed was that 1 in 4 HEMS patients, and again, not code red patients, but 1 in 4 HEMS patients had deranged coagulation. And the importance of that was that if your coagulation was not normal, you had a 4 times increase in your mortality. If your coagulation was intact, your death rate was about 10%, and if you had coagulopathy, it was 40%. And this was the first time they'd described a unique disease entity called ATC, which wasn't just due to hypothermia, acidosis and dilution, as we were all taught at medical school, being the lethal triad, but this was something that happened as a result of it, tissue injury and profound hypotension. So that started people thinking and talking about concepts like damage control resuscitation, damage control surgery. How could we try and limit this coagulopathy? And around 2007, the damage control principles really started to come into their own. And at that time, we didn't have a London major trauma system. We didn't have major trauma centre designation, but we did have massive transfusion protocols, and most big hospitals had these. But they were very, very different to the ones that we know now. So in pre-hospital, our resuscitation fluid was normal saline. And in most emergency departments, even for very sick patients, crystalloid was given in litres before blood products were available. And at that point in 2007, even at the Royal London Hospital, we didn't have blood in a fridge in the emergency department. We had to move up to the first floor or someone had to bring the blood from the first floor down to the emergency department when it was requested. And that induced delays in trying to transfuse patients who were exsanguinating. And it was even more frustrating for the pre-hospital teams who saw patients who they knew were bleeding, but they couldn't resuscitate them in the same way that they would in a hospital. And these transfusion protocols really didn't focus on getting early blood products. Sorry, that's for authenticity. That's the helipad alarm going off and the team about to go out. So on the basis of our feeling that we weren't doing as much as we could, we convened a panel in 2008, and everybody agreed that we need to do more to get blood products closer to the patients in the resuscitation room. So we set up a pre-alert protocol, and the essence of that was that the HEMS team, based on their interpretation of mechanism of injury, their clinical assessment and the physiology of the patient, in most cases they knew which patients needed blood, might get a massive transfusion and potentially needed damage control surgery. So they were in a position to alert the hospital and allow the hospital to do much more than a massive transfusion protocol, but something that became a massive hemorrhage protocol by activating not just the lab, but also activating senior surgeons, clearing the operating theatre, perhaps letting interventional radiologists know. And that became a whole bundle of care for this group that was known as Code Red. So the criteria were not evidence-based, but it was a blood pressure less than 90, suspected or active hemorrhage, and a non-responder to fluid, which is not criteria that's used now, because the ambulance service are very good at practicing permissive hypotension, and we don't really give crystalloid to anybody now unless we're absolutely desperate and have no alternative. But this protocol was started in 2008 and initially was just used at the Royal London Hospital. And you can see that some of the patients who activated the Code Red protocol in those days were actually largely blunt force trauma. And sadly, pedal cyclists versus HGV was a fairly common mechanism of injury. And you only really need to look at the state of the bike here, and you can imagine what perhaps the person riding it, the type of injuries they might have had, very similar to Vicky that Gareth showed you. So pelvic and lower limb, these patients are often GCS 15 to start with sometimes a chest injury, but often not. But frequently intra-abdominal and intrapelvic hemorrhage. Because it's an orthopaedic hosted meeting, I thought we should at least have a look at some bones and just remind people of the vasculature of the pelvis, which most of you will probably know in intricate detail. But of course, from a pre-hospital point of view, this is a real challenge for us. We can put a pelvic binder on, but this is non-compressible hemorrhage. And for patients like Vicky, if we cannot do something to attenuate the bleeding or increase her central perfusion pressure, as Gareth said, she's highly likely to die. And the mortality in that group of patients, so shocked with unstable pelvic injury, was over 60% in around 2007. And obviously we don't have imaging, we can't do CTs or X-rays pre-hospital. So our clinical assessment, looking at the position of Vicky's legs, as you heard Simon describing in the video, and actually trying to imagine in our mind's eye, what does her pelvic skeleton actually look like? Where do we think the bones are? Which vessels do we actually think are injured, and how can we try and optimize our treatment to actually save this young lady's life? Gareth also talked about thoracotomy, which is the other group. So as well as blunt force trauma, since 2008, we've seen, sadly, a very significant increase in penetrating trauma. And sometimes the Code Red patients aren't people who've exsanguinated, but they're patients who perhaps have a cardiac injury from penetrating trauma. They have obstructive shock, and it's the relief of the tamponade that will save their life. But they would still be considered a Code Red patient. Some of them may need some blood, particularly if they've got other intrathoracic injuries, but also they would need a surgeon ready and waiting for them at the hospital, and they might well need blood products. So whether you're a blunt force trauma patient or a penetrating injury patient, you could meet the Code Red criteria. And it's probably just worth thinking about in advance of Gareth Greer's talk about human factors, but performing those sort of procedures in the pre-hospital setting is very different to doing it in the resus room, where you have plenty of lighting, plenty of colleagues who are all trained to the same level and able to take on different procedures simultaneously. The HEMS team have a very different challenge. Often in those days, in 2007, 2008, one doctor, one paramedic, multiple tasks need doing at the same time, and trying to convene the team and get everybody working together, it can obviously be a challenge. And that's one of the sort of things we enjoy about the job, I think, is trying to make that team work effectively. But it is different to being in a hospital, and this is Malcolm Tunnicliffe at King's College, and you can see just from this still picture how energised everybody is trying to look after this code red patient. It's actually Gareth Davis in the background, probably trying to retrieve some kit, but he's obviously handed over, and you can see Malcolm is squeezing the blood in like his life depends on it, as well as the patient. But in 2007, 2008, we did not have the luxury of being able to give any blood to patients outside hospital, which was a source of frustration. And we worked on this. And then in 2012, we felt very lucky to have had the support from our transfusion lab, and we managed to get pre-hospital packed red blood cells out in little blood boxes, which we'd copied from the military, from the MERT teams. And what we managed to do over the next 3 years was reduce the pre-hospital mortality for this group from 34% down to 19%. Now, those of you who are thinking ahead will already have thought, well, doesn't that just mean that these patients survive to hospital and then they die? In some cases, that's absolutely right. And this didn't equate to a benefit in survival to discharge. But what it did do was push the major trauma centres to try and find the next intervention or the next pathway which might help this group of patients. But what we saw was an additional increase in the hospital deaths in the first 3 hours. And I'll show you a graph a bit later which makes that really clear. But it definitely helped us resuscitate patients, and it felt a lot better to have this available, knowing that we were transfusing a product which could actually carry oxygen. Alongside this, we were developing guidelines for using ROTEM to support our transfusion protocols at the Royal London Hospital. And this was because if you traditionally ask for an INR or prothrombin time, it will take about 40 minutes if it goes through the lab. ROTEM, or rotational thromboelastometry, gives you the ability to get a test result within about 5 minutes, which is obviously much more real time, much more useful to a trauma team. So this technology was being used by the research team and developed alongside clinical practice. Equally in 2013, as you've heard from Gareth, some pre-hospital enthusiasts, namely Gareth, Sami Sadek, and Robbie Lendrum, recognised that there was something else we had to do for this group of pelvic injury patients in particular, and they were aware of endovascular intervention that actually historically had been done years ago by vascular surgeons at the Royal London, but was coming back into vogue. They drove this from a pre-hospital point of view, but we started doing it in the MTC in 2013. And this is actually Sami being filmed by the BBC doing the first ever one inside the Royal London Hospital. And he's trying to get access into the common femoral artery to be able to insert the catheter. But this was a step change in the opportunity to help the pelvic injury patients in particular. You've already seen the video, Vicky, and that clip that you saw just makes it so absolutely clear how sick she was. But if you look at this still photograph, you look at the colour of Vicky's skin compared to the paramedic's arm, you can see that she is exsanguinating. I think the only blood pressure they saw was 40 systolic, and she was able to tell them her name, but you could see from the video how sick she was, how intent the team were on saving her. And some of the key things they did were just doing the basics very well, but also the absolute ability to intervene, to give her blood, to perform Roboa, and then to anaesthetize her, not only for humanitarian reasons, but to expedite her course through hospital to damage control surgery. In 2015, this paper was published in JAMA, and this was a total game changer for the transfusion world. There'd been debates about the ratio of products that should be given, so the ratio of packed cells to plasma in particular, and this paper looked at the ratio including platelets. It became absolutely clear that 1 to 1 to 1 was what we should be aiming for. And literally the British Society of Haematology changed their guidelines, which were due to be published that day. They changed them in support of this paper. So what we recognised then was that plasma, and even before that, we knew that plasma early was very important. And this is because we believe that plasma actually helps to repair the glycocalyx when the patients have ATC. It's also good volume resuscitation fluid because it contains the clotting factors and some fibrinogen. But at this point in time, plasma only had a shelf life in the UK of 24 hours. So to put it on the helicopter would have resulted in quite significant waste. The other thing that happens around this time is we recognise that the HEMS teams were being asked to do more and more intervention more and more quickly, because time is always key in these code red patients, because ultimately most of the ones that are super sick have non-compressible hemorrhage and actually need to be either in interventional radiology suite or in an operating theatre. And in 2017, we increased the number of HEMS consultants from 5 of us up to 16. And what these new appointments allowed us to do was to extend the hours where a consultant was on shift from probably several days a week to about 18 hours a day, covering half of the night shift at least. And this has allowed us to perform multiple procedures, for example, to do a subclavian line at the same time as a thoracotomy, or to do Reboa at the same time as undertaking a rapid sequence induction anaesthetic. So this has actually radically changed our potential for what we can do in the future. Sometimes it's 2 paramedics with a doctor, which is still of equal value and importance, just because having more trained hands who know the protocols is useful. And in 2018, again, with push from the pre-hospital teams, the Major Trauma Centre agreed under the UK Reboa trial that we would try and step up to deliver zone 1 Reboa, which is when the balloon is blown up in the thoracic aorta. So this gave us another opportunity to help a different group of patients who had intra-abdominal hemorrhage rather than just more the pelvic injury group. So zone 1 Reboa was brought in 2018, and the pre-hospital teams now are doing a feasibility study called PPRO, which is looking at whether that's deliverable from a pre-hospital point of view. The obvious issue is that the longer you have a balloon up in zone 1, the more ischemia you will cause to the rest of the body, and whether people are salvageable from that. But we're hoping that's going to have beneficial results. From a transfusion point of view, it can be very challenging pre-hospital. You often only have 1 viable IV access. You've got 2 people who are able to check the blood rather than tens of nurses in your resuscitation room. And what we were really pushing for was to try and get as close to whole blood as we possibly could. Now, whole blood doesn't exist in the United Kingdom for a variety of reasons, which I won't go into now, but are actually quite interesting considering it was available back in the 60s. But we collaborated with NHSBT and we got them to agree to produce red cells and plasma in 1 bag. And just from this picture, you can see that it is equal volume of each product, but it's in 1 bag. The logistical benefit of that to us is huge, because we can be giving a 1-to-1 ratio just by hanging 1 bag rather than having to open 2. And the time saving is really significant. So we did a study for 2 years. It was a feasibility study. And as part of that, we did a moulage study looking at how long it took different air ambulance teams to deliver the equivalent of 2 units of plasma and 2 units of red cells, just with a 2-person team. And it was a bit of a competition between Thames Valley, Essex and Herts, Kent, Surrey and Sussex and London. And each one had to go at each other's recipe. And you can see from the red box here, the flow time, just to give the red cells and plasma, it's fairly obvious, but it took 6 minutes 31 in total compared to up to 16, 17 minutes. So we don't know yet for sure whether there's a clinical benefit to that product compared to separate components, but we know logistically when time really matters and you've got a very small team, this might actually be something that's really important to air ambulance teams. What we really want though is whole blood, and we're hoping within the next 18 months that there'll be a national trial with several air ambulances involved to see if whole blood, so adding in platelets to the red cell and plasma, actually makes a difference. Just want to mention tranexamic acid. Gareth did mention it, and there's been quite a few trials over the last few years. Most people remember CRASH 2, and really important for code red patients that the major benefit from CRASH 2 was in patients where the blood pressure was less than 70 and TXA was given in the first hour after injury. The target used to be give it within 3 hours, and it's harmful after that time. But we now know that if you can give it in that first hour, it really does make a difference. We also know that the IM route is efficacious following recent studies. I think this slide is really important because we shouldn't just be thinking about TXA as an afterthought for code red patients, but for every 15-minute delay, the survival benefit for TXA is reduced by 10%. So someone today said to me, actually what you should do for code red patients is put a cannula in and flush it with TXA. And I get the idea, and it's probably not a bad idea. We should probably flush it with saline, but get the TXA in as soon as you possibly can. We changed the Royal London protocol a few years ago, and we took out the infusion dose, which was recommended by the CRASH 2 trial investigators. And now we give a 2-gram bolus for Code Red, and the HEMS team do the same. And all MTCs in London have accepted that a 2-gram bolus by the HEMS team doesn't need to have the infusion. And often further TXA is guided by ROTEM. So overall, how has Code Red affected mortality? It's actually, at the Royal London, over a decade, we've reduced the mortality from 45% down to 27%. And that has been monumental efforts by everyone, including LAS, the pre-hospital team, and the wider specialties that contribute to the trauma team, including orthopedics. And we're really grateful for all the support that we've had. And this just diagrammatically, I suppose, shows how incremental change can reduce mortality. The black bars are deaths in the first 3 hours, and the red bars are deaths from 3 to 24 hours. So you can see that blip in 2012 that I mentioned. We'd got the early deaths really down quite low, but then they blipped up when pre-hospital blood was brought in. But for me, that just presents a challenge to the major trauma centres. We have to find better ways to treat the patients once the HEMS team get them alive into the MTC. But you can see the difference that all of these little changes have made sequentially. If you want to read more about this, this is a paper we published a couple of years ago, and it goes into a lot more detail about how this was actually achieved. But the bottom line is, this is Vicky, the lady you saw in Gareth's video. She survived to tell the story, and I think we are all convinced that if we didn't have pre-hospital blood, the ability to do REBOA, expert teams, and a Code Red protocol where everybody works so hard together to alert the hospital and get everything ready, I think Vicky probably wouldn't have survived her injury back in 2007 when we had massive transfusion protocols rather than hemorrhage protocols. The Code Red team now looks very different, and we've made quite a lot of changes in trauma and anaesthetist experts being resident in the daytime, enhanced surgical teams with 2 trauma surgeons operating for complex cases, and the ability to activate an ECMO team for certain patients. But 28% of these patients are still dying at the Royal London Hospital, and it's probably similar in other MTCs. So we still have a lot of work to do. So I hope I've given you a bit of a flavour about how Code Red has evolved, but it's clear there's still a lot of work that we've got to do, but we look forward to that challenge.
That's awesome. Thank you so much, Anne. That was obviously covered a lot of stuff in terms of how it all started and how things have evolved over time. And yeah, absolutely. I think even when I was working with you guys back in 2013, it was very different to how things are now. I just maybe had a quick question. There's quite a few questions I was wondering whether, Anne, you could have a look at on the Q&A chat over the course of the next 2 talks, because there's some of them are very specific, and I suspect you have better answers than I do. But how do we share the good practice that kind of, you know, you've had in London with pre-hospital transfusion so that other services can kind of use it as a model?
Yeah, thanks, Ash. I think, I mean, I guess seminars like this are a really good start, and Zoom's allowed people, you know, not to travel to conferences, but to hear these sort of talks. And I think we've always been very open about sort of sharing protocols and trying to help other services do similar things. And often it's sort of local politics, like trying to get blood bank to accept someone else's policy and, you know, sort of, you know, realise that it's okay to do things in a slightly different way. Sometimes, as you know, we said before, sometimes change is difficult. But I think, you know, a lot of the things we've done are now in national guidance, which really supports people. If NICE guidelines say you should have a Code Red protocol or you should have one-to-one resuscitation, that just helps people break through some of the red tape. And, you know, as I said, it's simple things like validating blood boxes and just sharing good practice around that. Through Air Ambulance Association has supported some of that work, and I think now through the National Trauma System, you know, MTC directors and network managers are very keen to sort of share good practice.
Awesome, thank you so much.